Okay. Welcome to the talk. And as always, I'm impressed that they, at the moment, 234 healthcare workers listening to this. So well done. And what's unusual about today's particular episode, as it were, is that I don't have load shedding scheduled. It seems like every single other time, wherever I've been, load shedding has been scheduled. But today we've got lucky.
Yeah.
So when I was approached by Amanda to give this talk, she said, what would you like to talk about? And I said, complicated TB. And then I realized that complicated TB is not actually a medical term, and it doesn't have a definition. What I'm going to talk about is anything other than ordinary pulmonary TB. So anything from extrapulmonary tuberculosis, meningitis, drug-resistant TB, something that's a bit unusual. And I'm hoping to increase the awareness of TB, how we treat it. And even it doesn't matter where you work. What's important that is if you see these complications, you need to know how to and when to refer them for specialist care. So what I'm going to do is I'm going to go through some of the definitions that do exist. And then I'm going to have a quick reminder of uncomplicated TB disease. I'm going to talk about extensive pulmonary disease, extrapulmonary disease, and then finally, no one will get to sit through a talk with Francesca on TB without me mentioning the subject of drug-resistant TB.
Yep.
Okay. So the WHO has come up with a term to describe extensive pulmonary tuberculosis. They use a term interchangeably. They also call it advanced TB. I think for those of us who work in South Africa, I think that the vast majority of TB that we see radiologically is advanced TB. And the definition of it is the presence of bilateral cavitatory disease, so cavities on both sides, even if they're small, or extensive parenchymal damage on chest radiograph. I'm going to show a couple of x-rays, and I'm going to ask you to vote on whether you think this is extensive or advanced pulmonary disease. Of course, children have a slightly different experience of TB from adults. Children very seldom form cavities, and the presence of cavities in a child under the age of 15 is defined as extensive disease, or if there's bilateral chest disease on a radiograph. What we do know is children tend to have a different type of disease, more porcibacillary, and as we know from some new clinical trial results, many of these children can be treated with a shorter all-oral regimen. But just to reiterate, extensive disease is bilateral cavitatory disease or extensive parenchymal damage. I'm going to go to my next slide. I want you to have a look at this x-ray and decide. I'm going to ask you to vote in a second, and I'll show you how to go through the voting. Remember, the definition is bilateral cavitatory disease or extensive disease, extensive parenchymal disease. And I'm going to ask you to vote on this next slide whether you think this is extensive TB or not. Now, the way we use the Slido app, there are two ways that you can do it. The first one is if you're linked in on your laptop, what you do, and I'm demonstrating it, is you take your camera and you take a picture of the QR code and you click on the QR code, and that's going to link you straight into this presentation. If you are on a laptop, what you can do is you can open a separate window, a different window altogether, type in slido.com, and then put the number 2466172. And you can decide whether you think this is extensive disease. I'm going to give you about a minute or so to get used to the platform. So either use your cell phone and take a photo, or open a different window. And on that window, what you need to type, look at slido.com and then 2466172. Okay, guys, go for it. So far we have, I beg your pardon, I need to go back. Oopsie. You have to vote again, guys. I messed it up. Oh, there we go. It's working. It's working. Sorry. Okay, keep voting. Keep voting. I want to note also that this definition is outside of whether or not the patient has got HIV. So this is a marker of extensive disease, deciding whether or not, doesn't matter whether the patient's HIV affected or not. Okay, I can see the votes are starting to slow down. And what we've got, if you have a look at the poll, is around 2/3 of us, and you can see which way I'm voting, thinks that this patient has got extensive disease. I'm going to go back to the slide, because now I've given what I think is the answer, and I'm going to tell you why I think it's extensive disease. If we have a look, I think that this patient here has got bilateral cavitatory disease. This is a huge big cavity here. So this is a big cavity. Can you see my marker, Lesego?
Yes, nice and clear. Thanks.
Okay, so there's cavities. I think that there are a couple of cavities in here. And it appears to me that the entire right side is occupied by what looks like a vague infiltrate, perhaps even a miliary kind of pattern. So I think this patient has got extensive TB or advanced TB. Okay, I'm going to go to the next slide. Okay, this is another chest x-ray. You will all note that this is the chest x-ray of a female. And remember, what I want you to vote on is, do you think this patient has got extensive TB or not, based on this chest x-ray? Remember, extensive is based not on HIV status, but only on the chest x-ray findings. So again, we're going to go to the voting poll. Do you think this patient, oopsie, do you think this patient has got extensive disease? So remember the same thing, you either use your cell phone, or alternatively, what you do is that you log on to Slido and use the numbers 2466172. Keep voting, guys. Be brave. I don't know who you are, so it doesn't matter whether you get it right or wrong. I don't know who you are. Keep voting. Be brave. Okay, voting's, I'm going to give you 10 more seconds. Okay, and we're going to go back to this, oopsie, keep doing it the wrong way, to this chest x-ray, which was the x-ray I showed you just now. And the votes were pretty much for, doesn't help that I'm getting this all mixed up. Okay. So this one is supposed to go with this poll, and I've just mixed them up. So I think, and I'm sorry, I have to redo this. I think that this patient does not have extensive disease. She's got some elements of cavitation. I see someone disagrees. I think that this patient, if we have a look, the cardiac shadow is normal. So we can see a nice normal cardiac shadow. We can see clear margins, no costophrenic angles, a little bit of an infiltrate. But I think a lot of this is actually bronchial markings. And I think that this patient has got non-extensive disease. Okay, I get some votes, even though I mixed up the poll like a silly Billy. Okay, let's go to the next slide. Okay, this one. Who thinks that this patient has extensive pulmonary disease? Okay, I'm going to go to the poll and keep the poll right this time. Do we think that this patient has extensive disease? Okay. Does this patient have extensive disease? Keep voting, guys. We seem to have a majority, but we don't want to pip the post. No early runners. Do we think this is extensive disease? For those of you not voting on Slido, I do see thumbs up. So you think this is extensive disease?
I see a lot of yeses in the chat. I know we've got the born before technologies will prefer to type.
Yes, okay. I see the hands going up and people voting yes. So if we go back to the chest x-ray, this chest x-ray, this patient has definitely got extensive disease. Remember I said bilateral fibrocavitatory disease. And if we have a look, here's a huge big, it's not even a cavity, it's a bullous with a lot of little ones, some on the other side. The chances are this is not the patient's first episode of TB, and this is extensive disease. We kind of got a little bit blasé about this because we look at a chest x-ray and go, this is definitely TB. And this was TB, that is correct. But this is extensive pulmonary disease. It means that it's more difficult to treat. How do we get drugs into this particular part? That's air. We can get drugs around the edge, and they've got to penetrate into the cavity. And even these little cavities, like that's a little cavity. How do we get drugs in there? It's a totally, this is quite extensive disease. We've been voted in on a ticket of TB is curable. And there's no doubt that if this patient has drug-sensitive TB or drug-resistant TB, and they are adherent to their therapy, their chances of being cured are very high. But this patient will have post-TB lung disease. This cavity that we see on the top right-hand side will remain a focus for infection, not necessarily TB, but the patient will continue to get pulmonary infections, and there's loss of volume. So what I'm trying to stress by this is one of the most important things to do is to diagnose our patients early so we don't see this kind of pattern. Okay, I'm going to go to the next slide. Okay, this, I'm sorry, it's a bit of a yucky x-ray. It's not a very good quality. It's an over-penetrated x-ray. But again, what I want you to do is to vote on, is this extensive disease or not? I don't know how to reset polls. I've totally messed this one up. Okay, so I see hands coming in. Lots of people have voted. I don't know if it was on the last x-ray on this one, but people think that this is extensive disease. Anybody voting that this is non-extensive disease? I'm reading all the messages as well. I was also born before technology, but most people are agreeing that this is extensive disease. Okay. So just to park that thought, I think that in South Africa, I work with international collaborators, and people say, TB is pretty simple to treat, and they show me an x-ray and I look at it and I think, oh, do I even see anything on that x-ray? And we are so used to seeing such advanced disease that we think that it is the normal pattern of disease. It isn't. The x-rays that I've shown you have got extensive lung damage, and sometimes that is incurable. The last x-ray that I showed you showed right upper lobe disease, and sometimes the only way to cure that patient from their TB is to actually consider a lobectomy. Quite radical thinking, but we've got to be a little bit more aggressive about how and why we diagnose TB and to treat it very vigorously with the correct treatment first up. It's very similar to breast cancer. If you find it when it's early, it's easy to treat. If you find it when it's late, you can sometimes rescue the patients, but not always. Okay, then the next thing that I'm going to talk about is, we've talked about extensive pulmonary disease. I'm going to talk about extrapulmonary disease. Now, there are a couple of things that are important in this definition. The first one is it's got to be bacteriologically confirmed. You can feel a lymph node in someone's neck, and I dare anyone to make that diagnosis of TB lymphadenitis without bacteriological confirmation. Lymph nodes, they do have a particular feel to them. It's got a term that we use in patients with lymph nodes in their neck. It's called scrofula. And when you feel it once or twice, you know it. They're matted lymph nodes. Often they have sinuses. But we do need microbacteriological confirmation. And the reason that we need it for the external lymph nodes is that not all TB is rifampicin sensitive. And not everything that affects TB lymph nodes is rifampicin sensitive. And the last thing we want to do is to embark on a course of treatment that is not going to be successful because we've chosen the wrong drugs. So TB can affect the lymph nodes. It can affect the pleura. And there's a reason why I've put these two extrapulmonary sites together, the pleura and the lymph nodes, is because although they are strictly speaking extrapulmonary, they are outside the lung tissue. Often their prognosis is very similar. You can get lymph nodes anywhere that are associated with TB. I've seen some deep in the axilla, the only place that I could find the TB. Some obvious ones around the neck, but they can be in the inguinal region. They can even be in the abdomen. You can also get abdominal TB, which is more than just lymph node TB. It's often associated with ascites. You can get genitourinary tract TB, skin, bone and joint, and meninges TB. Now, the problem with the diagnosis of extrapulmonary TB is sometimes it's difficult to make. And also, we don't have any method of saying when the patient has had enough treatment. We know in the treatment of lymphadenitis, particularly in children, that the lymph nodes settle down, but they're still matted. And we can't tell whether these are cured TB. We don't have a microbiological way of being able to prove it. So that's one of the challenges with extrapulmonary TB. Whoopsie. And the other thing with extrapulmonary TB is if you look for it in the HIV-infected patient, you will find it. So even if you make the diagnosis of pulmonary TB on a chest X-ray, then you do an abdominal sonar, you will probably find lymph nodes in the advanced HIV patient. So the more you look, the more you will find. It often is extrapulmonary as well. As promised, as always, what I want to remind everyone is that not all TB is simple pulmonary TB. Some of it is resistant to our first-line drug, rifampicin. And I just want to run through the numbers in your own head. So for every 100 TB patients that we diagnose, 4% of them are rifampicin resistant. I'm very grateful to be working in South Africa, where we should be using the Gene Expert as our diagnostic tool. And the Gene Expert will tell you immediately if the organism is Mycobacterium tuberculosis, number one, and second of all, whether it's resistant or sensitive to rifampicin. The definition of multi-drug resistant TB is resistance to rifampicin and INH. And because we're kind of phasing out the use of INH in the treatment of drug-resistant TB, we kind of now call it rifampicin-resistant TB, as opposed to full MDR. but it is a real danger. And I always say that when people see a test that says Mycobacterium tuberculosis resistant to TB, their heart rate increases. And I'm talking about the doctors and the nurses. They panic, they don't know what to do. And in fact, the treatment of drug-resistant TB is a simple 6-month all-oral regimen. It doesn't involve injectable agents anymore. It's pretty simple to treat. You just need to refer it to the same place. People are concerned, doctors and nurses are concerned when they see drug-resistant TB about infection control. But personally, I don't want to get TB. I don't care whether, I mean, I would prefer it not to get it at all. But if you look at those chest x-rays that I showed you before, many people who get TB do not emerge unscathed at the end of it. They have ongoing problems even once their TB is cured. So infection control, that was kind of brought into fashion with COVID, is something we need to observe amongst our patients. And we need to think that everybody has open cavitating TB until proved otherwise. Wearing masks ourselves, and coughing patients need to wear masks to prevent the transmission of TB within our facilities. I'm not going to belabor the point, but the definitions of extensively drug-resistant TB has changed. We now call pre-XDR TB resistance to a fluoroquinolone as well as rifampicin. And if we look at the numbers, if 4 of our patients out of the 100 are rifampicin resistant, about 1 in 4 of them will be fluoroquinolone resistant. We've got treatment, we know what to do, you don't need to panic, you just need to refer to appropriate units. And then finally, we've got a new definition of extensively drug-resistant TB. We've got wonderful new drugs for the treatment of TB that have been invented in the last 10 years or so. We use them, but if our patients are resistant to any of these drugs, we call this now XDR TB. And if we have a look at the numbers, probably there are 500 cases of extensively drug-resistant TB that occur in South Africa every year. And that puts us pretty much as front runners of all of this. What do we need to do to counteract this? Find the diagnosis early. If you think someone might have TB, even if you don't think they've got TB, particularly if they're HIV co-infected, send off a gene expert. Find out if they've got it, put them on appropriate treatment. To stop TB transmission within our communities, we need to find, test, treat, and cure as many people as we possibly can. Okay, so that was our quick Cook's tour of drug-sensitive TB, of drug-resistant TB. Let's talk about drug-sensitive TB. And I can hear you all falling asleep because, my word, we've been saying the same things for so many years. So the treatment of drug-sensitive TB until very recently has not changed since I qualified. It consists of 6 months treatment, and it's got the same kind of feel as, for all the women who are in the audience, you know, you get one-size-fits-all stockings. That's how we treat tuberculosis, one size fits all. And we can see already from the x-rays that I've shown you that not all TB is the same. That some people have, and it's a lay term, it's not a medical term, they have a touch of TB, and some people have really extensive TB disease. But we treat everybody with 6 months. It doesn't matter whether you are HIV infected with a CD4 count of 1 and kind of miliary pattern on your x-ray, or whether you are a 25-year-old healthy HIV negative young man with an almost normal chest x-ray. We treat you exactly the same. The World Health Organization came up with this idea in the 70s, and almost nothing has changed since then. It means we are over treating a bunch of patients and probably under treating a few, but not all that many. So the treatment is, as we know, the combination of ionate, rifampicin, ethambutol, and PZA. We give this for 2 months, and then we give a continuation for a further 6 months. And the treatment is exactly the same as I've mentioned. There are purple pills. What we use in South Africa is a drug called Rifa-4. Usually, you swallow your tablets, and everyone is treated exactly the same. How do we monitor someone with just ordinary, standard, uncomplicated TB? Although we use GeneXpert as the way to diagnose TB, we cannot use it for monitoring. We do a smear at the beginning of treatment, and then we repeat the smears at 2 months. What do we do if the smear is still positive at 2 months? Panic is not the correct answer. If it is still positive, then we don't just continue for another month. We've got to look for reasons why it's still positive. Now, the reasons why it can still be positive is, first of all, that your patient is not taking their medicines. And you need to inquire about drug adherence in a non-judgmental way. Or the other alternative is that you're using the wrong drugs. That for some reason you are giving rifampicin to a rifampicin-resistant patient. So gone are the days where we just continued the treatment for another month. There are late converters. There are some people who are adherent to their therapy but convert late. But most of them, there is a problem, either non-adherence or resistance. We repeat the smear again at 6 months, and we do the same thing. If it's still positive, or if it's reverted to positive, is the patient did the patient finish their medicines, or have we missed any resistance? The TB program is very regimented in its approach to control of TB, to outcomes of TB, and it should be. And that's why we've been able to reach the broader community with pretty simple drugs. However, and it's one of the reasons why the private sector is not so good at it, because you've got to make sure that every patient you initiate on treatment comes back at 2 months, coughs in a bottle, and you decide whether this is patient on their way to cure, whether they've smear converted or remain smear negative, or alternatively, whether there's something else that you need to do. And we need to treat TB, the potential of TB resistance aggressively. Because if we don't do that, what we're going to see is another clone of TB coming out that is resistant to our current medications. South Africa is one of the few countries that took a hit during COVID, but has managed to start to get back onto the road in terms of TB control. I don't really like the word TB control. The TB program is getting back together. We're starting to test enough patients. We're starting to look for it again. So we are recovering, but we've got to make sure that patients initiated on therapy complete their treatment. We haven't had any new progress in the treatment of drug-sensitive TB until, of course, I'm going to mention the study 31 shortly. But the side effects of drug-sensitive TB, skin goes orange. You can get redness or photosensitivity of the skin. Patients complain of nausea, diarrhea, and loss of appetite. And in randomized controlled trials, when we have really looked for adverse events, this regimen is well tolerated. However, if a patient says, I feel sick every time I take the medicines, don't just say goodbye. Consider giving them something to help with that nausea. We've developed quite a laissez-faire attitude to adverse events associated with TB treatment. You know, the kind of grin and bear it, you've got to get on with it attitude. And that's not a correct attitude to have. If we want our patients to adhere to therapy, what we need to do is to make it as easy as possible. In antiretroviral therapy, we've gone from medicines that you used to have to take with food twice a day with terrible side effects. And now we've got a really simple treatment for the vast majority of our patients, because we know that people will not adhere to therapy in the long term if they're getting side effects, particularly if the side effects are worse than the disease itself. Some patients complain of pain in the right upper quadrant. Joint pain is quite common, and the joint pain is often associated with pyrazinamide. Remember, PZA is in the intensive phase. We only give it for 2 months, and it's a very useful drug, but it is not really tolerable in the long term. Many of our patients complain of joint pains. And again, try a little bit of non-steroidal anti-inflammatories, but if the patient cannot manage with the joint pains, then what you need to do is to stop PZA prematurely. Please do this with specialist advice, because it will depend on the burden of disease that your patient has, whether they are on the way to smear converting or not. Patients also complain of mild headaches, difficult side effect to pin because many of us get mild headaches, and sleep disorders. I think an area where we really have fallen down in the treatment of TB is that we have kind of ignored mental health issues. You've got TB, you get squashed into the sausage machine of TB treatment, and our treatment is quite effective. But we forget that our patients come from social circumstances. TB is a stigmatized disease. And one of the things that worry people with TB is, what if I've given it to somebody I love? What if I've given my TB inadvertently to my child? I don't want to do it. And I think we need to address the issue of depression, feeling blue in TB. Otherwise, we're going to lose our patients for mental health reasons. And that's a great pity, because if we can retain them in care for a short period of time, 6 months is a short period of time, then we can cure or at least put them back onto the road of health for the vast majority of them. And now, for the first time, and I've mentioned this before, what we have done is in a very large randomized controlled trial called Study 31, what they did is that they compared the treatment of the standard of care, which is HREZ, to a shortened rifapentine-containing regimen with moxifloxacin. And for the first time in our lives, we actually have an alternative. I know that these are strange names, Remox, Oflatub. They're all studies that have been done that have cost millions of dollars to try and shorten the course of TB treatment. And almost all of them have failed, except for Study 31, which showed that we can use a shortened regimen with rifapentine and moxifloxacin. I'm not going to go through the details of the study, but for the first time in my life, there's actually been an alternative. And what we need to do is, just like we have HIV advocacy to find the best treatment for our HIV patients, we need to start looking at encouraging, advocating the National Department of Health to start to make this available to South African patients or patients who live within our borders. We still need a little bit more evidence on pregnant women. As always, pregnant women, the research done in pregnant women, we treat pregnant women as very precious individuals who are just a womb surrounding a baby, as opposed to women who have health issues of their own, and we need to make sure that they are adequately represented in clinical trials and in our practice. This study was conducted in many sites, not only in sub-Saharan Africa, and because of that, we don't have full information on patients with CD4 counts less than 100. We're not sure whether this works in children, and we're not 100% sure about dolutegravir, although the work done to date shows that there are very little drug-drug interactions. So what we need to do is to get on our soapboxes. We need to talk to the Department of Health about starting to introduce this. So we know that the shorter the treatment regimen, the better the adherence. And this is very exciting. I try to mention it in all my talks. An impressive piece of work. And now we need to take it to the next step, which is implementation within our program. So, as I say, the first time, and when I look at other conditions that we treat, there's no other condition that's treated, in my experience, except for maybe syphilis, that's treated the same way as it was when I was an intern. And yet TB, finally, people are waking up to the fact that this is a public health problem, and TB everywhere is TB in your own country. Okay, so we've talked about, I did a quick revision of the treatment of drug-sensitive TB. It's pretty easy to do, but new things, none of us like change. New things are underway. So when you hear about a rifapentine-containing regimen, just remember that this is something that your patients can potentially only have to take for 4 months. Great news. So when we look at the chest X-ray, we're looking at the presence of unilateral or bilateral disease. We've talked about the presence of cavities. Cavities, sometimes we have discussions about whether this is TB or not. Look for pleural effusions, and then look for the cardiac shadow. TB can cause TB pericarditis. And what happens then is you see a bulbous kind of chest, a cardiac shadow. This is a health emergency. And it's one of the very few times we would delay antiretroviral therapy. So extrapulmonary TB, as I mentioned before, we divide it into complicated and uncomplicated. If you see a pleural effusion, and in fact, the World Health Organization is advocating to change pleural TB or pleural effusion into pulmonary TB, because in fact, it responds very well to treatment. It responds remarkably well. Whenever I see cases of this, I think, sure, this person is drowning in fluid, and then 2 weeks later, I take an X-ray and it's almost completely resolved. So it is, although it is by definition extrapulmonary, it behaves like pulmonary TB. Then the complicated ones, the ones that we have more difficulty in making a diagnosis and often have to have extended treatment. And we've got very little clinical trial advice on how to actually treat this. Just beware when you do see a chest X-ray with a massive effusion, that not everything that is an effusion is tuberculosis. We do need to make the diagnosis, and ultimately the diagnosis is made by the detection of Mycobacterium tuberculosis in the pleural fluid. And we can find it either by gene expert or by culture. You can do a pleural biopsy specimen, which is a terrible thing to do to a patient. And it is a terrible thing to have to do as a doctor. But if you do see granuloma formation, then that makes the diagnosis. But in South Africa, which is largely it's a high burden country. In fact, we're in the top 10 countries in terms of burden of TB. We can get away with tapping the fluid. If there's a lymphocyte predominance and a high ADA, we can make the diagnosis. This is not an excuse to practice bad medicine. We still need to send that the pleural fluid off for gene expert and culture, because not all TB is rifampicin sensitive, and we want to make the best diagnosis as possible. In the treatment of pleural effusions, there is no place for the use of steroids. So even if it's a massive pleural effusion, we can tap it if we feel that there's respiratory compromise, but if not, we do not add steroids. And we give appropriate TB treatment. There's a strange thing that pleural TB is often smear negative and gene expert negative. So if you suspect it and you do an X-ray, tap the fluid. If it's bloody, then you know you've either done a bad tap or there's a more sinister diagnosis. But if it's straw-colored, send it off for an ADA and for microscopy. And if then the diagnosis of pleural fluid is made. Lymphadenitis, this is actually a Cyndi Lauper song. If you look for it, you will find it. So if you look hard enough, you're going to find it. Where do you look? So even if you've got a pulmonary diagnosis, look to see if there are hilar lymph nodes. Hilar lymph nodes are particularly common in children and may in fact be the only manifestation of TB. Look for superficial lymph nodes, the ones that you can find. And if you find them, try and do an FNA with culture and gene expert. Of course, we're not going to go and biopsy a lymph node that's a para-aortic lymph node. Your MPS needs to be paid up for that. That is a little bit aggressive. But if you find lymph nodes in the supraclavicular area, in the axilla, and you don't have a tissue diagnosis, or you don't have a microbiological diagnosis, this is the time that you need to send off an FNA. You can do cytology, but the real joy comes in a culture and a gene expert. And that's because we've gone past the days of trying to make an empirical diagnosis of TB. What we want to do is to base our diagnosis of TB on laboratory testing, because we want to make the correct diagnosis. Tuberculous meningitis. This is the most devastating, without a doubt, form of extrapulmonary TB. As I've mentioned it for the first time here. Around the world, around 10 million people get TB. We're starting to find them more and more. 1.4 million people die every year, and about 30,000 people in South Africa die of TB every year. And again, we're quite blasé about it, yet another TB death. But we need to really investigate advanced TB disease and see if there is anything that we can do to change the pattern. All of us have seen very hectic patients presenting with a BMI of 10 and albumin of 10, and those patients are very difficult to rescue, but we need to be a little bit more aggressive. And in fact, if I was the Minister of Health, I would start to do M&M meetings as to why TB patients are dying, and if there is anything we can do to alter that trajectory. So tuberculosis meningitis is one of the most devastating consequences, and unfortunately, it tends to affect children the most. One of the reasons why we give a BCG is that it does decrease the incidence of tuberculosis meningitis. And TB meningitis in children, it is very seldom that a child will emerge from a diagnosis of TB meningitis unscathed. It's difficult to diagnose. The way that it presents, it's the same as ordinary TB. It starts off in your lungs almost always. Even if you drink unpasteurized milk, this is usually where it starts. When you get the primary TB infection, you get a short bacteremia, which can drain to the lymph nodes but can become hematogenous. And then when TB becomes active, and in children, this timeline is shortened. So in children, they often get their primary disease, and then it can spread to their meninges within a very short period of time. In a world where we can follow up kids a little bit more rigorously, if they get primary disease, we can watch and wait. But in South Africa, because patients have difficulty in coming to the clinic, sometimes it's a long journey, there are costs involved. That's why we treat all children with a positive skin test, in the fear that if we don't treatment, they can get tuberculosis meningitis. Tuberculosis meningitis also affects HIV-infected people, particularly advanced disease, and the elderly. What does it look like? So what are the symptoms of tuberculosis meningitis? Often it's subtle. People, they have signs and symptoms of TB disease. They may complain of a low-grade headache, nothing that they really want to write home about. They may have a low-grade fever. You might not even document it at the clinic, and they feel tired. After a period of time, if it's not adequately treated, they start to get CNS signs, which can include dizziness of vertigo, vomiting, and personality changes. Once the patient presents with a severe headache, an altered mental state, a stroke, hydrocephalus, or cranial neuropathy, while these patients should be treated aggressively, it is very seldom that they come out of this okay. So the idea is for us to bear in mind that particularly in children and advanced patients with advanced HIV disease, that there are chronic meningitides, and the way that we make the diagnosis is usually by lumbar puncture. I'm saying usually. Remember, cryptococcal meningitis fits in this group as well, and we can include or exclude the diagnosis of cryptococcal disease with a blood test. Obviously, if it's positive in a patient such as this, we would do a lumbar puncture. So tuberculosis meningitis, I wish that I never see another case as long as I live. It's a terrible disease and potentially preventable with early treatment. Always have a high index of suspicion. Someone with a CD4 count below 100 who complains of these non-specific changes, you need to have a pretty good reason not to refer them to hospital or not to refer them to a clinic for consideration of a lumbar puncture. I'm not saying you always need to do it, but it's usually a combination of things that helps us make the diagnosis. And I always found it bizarre. We're living in the year 2022, and yet we have very bizarre methods of finding this devastating disease. We do a CSF, we look for lymphocytic predominance. Usually in tuberculosis meningitis, there's an increased protein level. If the glucose is more than half of what it is in the bloodstream, that is a sign that something really bad is going on in that patient's CSF. I have yet to see a patient with tuberculosis meningitis who is AFB positive. So we stain it, but it's very seldom that we actually find the condition, so that we find acid-fast bacilli. Maybe I haven't seen enough, but we seldom find it. What you do need to do when you do an LP on patients that you're suspicious of tuberculous meningitis is you need to culture the CSF, because tuberculous meningitis that's not treated with the correct treatment, you have no chance of saving the patient's life. And the other one is you can run a gene expert on this as well, and you might be able to find small amounts of the DNA of the tuberculum, which will help you to make the diagnosis and certainly will guide you in terms of giving the correct treatment. So how do we treat it? We give effective antimicrobial therapy, and that's almost always HREZ for a prolonged period of time. And this is one of the very few times when we consider the giving of corticosteroids. We give steroids from the beginning of treatment, and we taper them off over the first 8 weeks of treatment. And we give supportive interventions to reduce intracranial pressure. Sometimes it might be a shunt, or sometimes just repeat treatment. What's interesting about our TB treatment is that rifampicin is the hot number. Rifampicin, I'm going to call her a she. She is the one who has enabled us to shorten the TB treatment. But INH is the one that is particularly effective in the treatment of CNS disease. So we continue, so INH is an absolute must. If your patient is INH resistant, then we need to look and make sure that ethionamide, it's free and it's not going to work, but we need to give it, INH is the cure to is the key to the cure of tuberculous meningitis. Rifampicin, it does penetrate into the CSF, but not all that well. And lots of work has shown us that we are generally underdosing our patients with rifampicin. We can easily go up to 20 or 30 milligrams per kilogram of rifampicin. So in the case of tuberculous meningitis, I would give an increased dose. PZA, it gets into the CSF, but doesn't have good bactericidal activity. And what you need to do is to kill those organisms as quickly as possible. Ethambutol, in my opinion, is a freeloader. I'm not entirely sure why it is in our regimen. It's not particularly useful. It's supposed to protect against resistance, but I'm not sure that it does that. So we give ethambutol just because it's part of Rifa-4, but I'm not sure that it does anything, particularly not in the treatment of tuberculous meningitis. So as mentioned before, in general, we do not add steroids to the treatment of TB to damp down the immune response, not for the treatment of a TB iris and not for the treatment of general TB. But we do use dexamethasone in the treatment of drug-resistant of tuberculous meningitis, I beg your pardon. It's very, very important. As we know, once you're an adult, your skull bones have fused, and if we don't decrease the pressure, increased intracranial pressure can be fatal. Again, one of the very, very few times when we suggest the delaying of antiretroviral therapy. In general, we want to initiate ARVs 2 to 4 weeks after the initiation of TB treatment. But in the case of tuberculous meningitis, this is one of the times we cannot afford any form of immune reconstitution syndrome in this case. Remember, if your patient has got drug-sensitive TB and you are using rifampicin, you need to double the dose of dolutegravir. And by doubling the dose, I don't mean give 2 tablets in the morning, I mean split the dose. So you give 50 milligrams in the morning and in the evening. There are occasionally patients who, for some reason, cannot tolerate or have some problem with dolutegravir. And in this case, what we can do is we can give a double dose lopinavir-ritonavir if, for some reason, the dolutegravir is not well tolerated. I beg your pardon. So what we need to do for the treatment of tuberculous meningitis, we need to make the diagnosis early. And I can tell you now, if it crosses your mind If you even think that this patient may have tuberculous meningitis, you need to do a lumbar puncture and make sure. Aggressive treatment of hydrocephalus. Watch out for hyponatremia, which can come from either severe nausea and vomiting or SIADH. Feed the patients adequately. Many of these patients present to our services really, really skinny with BMIs that are almost, that are ridiculously low. And initiate rehabilitation. As soon as the patient can get up and walk around, the patient must begin rehabilitation. Okay, this is an interesting slide, which I have stolen unashamedly from Kogi Naidu, who is the TB specialist at Caprisa. We used to have slides that looked like this for HIV treatment. You know, this is an integrase inhibitor. This is a non-nucleoside reverse transcriptase. And what she has done with this study, with this slide, is had a look at where the drugs work for TB treatment and where the new drugs are coming along. And I think it puts it together really prettily. If we have a look, I'm going to get my little pointer. We can see that there, and what's interesting is the way she's colored these slides is what's coming along. There's some registered drugs like linezolid that targets the ribosome. There's some registered drugs like bedaquiline, for example, that targets ATP synthase. And what that does is to decrease the energy within the tuberculous cell. But what's, I think, particularly interesting is if we have a look at, we actually finally have an active pipeline of drugs that could one day come into our system of for the treatment of drug-resistant TB. Never in my life have we had such an active pipeline of drugs for the treatment of TB. Finally, we're getting somewhere. Doing trials in tuberculosis, I know because I've done them. It takes a long time. It takes years. But what we have been able to do is we've been able to register new drugs because of the trials that we've done, and we've been able to shorten the TB treatment and change and improve the outcomes for patients. So hallelujah for this. You will never escape a talk on complicated TB from Francesca without being able to hear about the new exciting things that have occurred. Our current TB Chief Director of TB, Dr. Norbert Njeka, is one of the most forward-thinking TB doctors in the world. And I don't say that lightly because I've met many other TB program heads. And what he has enabled us to do is to include the treatment, to improve the treatment of drug-resistant TB by including new medicines soon on. This is a study called NIX, where we looked at extensively drug-resistant TB by the old definition, and we got a success rate of 90%. So in a group of highly treated 50% HIV-infected patients, we were able to treat them and successfully treat over 90% of them. And this is a great step forward. We've refined the dose of the linezolid because in this particular dose, we used a very high dose and got lots of side effects. But who would have thought, I would not have thought within my career, that we would have translated a disease with a 20% mortality rate into a disease that's curable 90% of the time. This is being rolled out already and is part of our TB recovery plan. South Africa, I wish I had a South African flag to wave. You know, we've got problems and we've mentioned them before, things like load shedding. Let's not go down this pathway, but we've been able to really change the lives of our TB patients by improving their treatment outcomes. So in conclusion, and then I'm going to open the floor to questions. TB comes in all shapes and sizes. If you're breathing, you're at risk of getting TB. If you stop breathing, then you're no longer at risk. You're also no longer alive. So it can be something as simple as a mild infiltrate that's easily treated with 4 to 6 months of treatment, to a thing that causes 30,000 South Africans every year to die. I always have to correct that. 30,000 people who live within our borders can die of TB every year. It's a great pity because we have, in fact, come a long way. We've got treatment, and the fact that it's still so prevalent is a great pity. We've adopted a very public health approach to the treatment of of TB in general. One size fits all, no discussions. You take your pills. If you get a side effects, well, that's a bit of a problem. But what we're starting to see is a change. And what that change is called is stratified medicine. We are starting to be able to tailor treatment regimens to the type of TB that patients get. And that's a great step forward. It's really an interesting time to be working in the TB field. So things are changing. And this talk is to remind you that, first of all, TB happens all the time, all over the place. Some people have very clear contact, some people don't, some people get it from who knows where. But it is, the sooner we find it, the better. And what we need to stress is that everybody who is HIV infected, we need to ask them if they've got signs and symptoms of TB and have a low threshold. You know, we can do, and I'm not joking, we can do up to 5 million gene experts per year. Let's do it. Let's do as many as we can, because every single case that we find is a case that we can stop transmission, we can stop someone else catching the TB from them, and we can save that particular person's health and often their lives. With that, I've got one more poll, and I want you to type a word of what you thought of this presentation. If you want to say, I wish there'd been load shedding and I could have opted out of this call, type it out. If you think it's been interesting, if you've learned new things, please type a couple of words in this place using Slido. Again, I don't know who you are, so if you say something, whatever you say, we'll use it as a reminder on how to improve our performance going forward. Okay. I'm going to leave you.
Type on the chat, type on the app.
Then are you typing these in?
I'm trying to catch up. People are on the chat. I should have blocked the chat.
I like this breathtaking. I like that. Yeah, because if we don't find the treatment of find TB, then it takes your breath away permanently.
It's coming through.
Yeah. Oh, shame. Someone got load shedding and kept dropping the call. I'm sorry about that.
We at least have a new pipeline of drugs, so we should forget about load shedding a bit.
Yes. Okay, what I'm going to start doing is, if this is okay, I'm going to start going through some of the questions.
Yes.
If that's okay.
Yes, before you start, just to say, colleagues, thank you for joining us. We are continuing with the session, and we will deal with all the possible questions at least until 7:30. Yeah, I think you can take them as they come, Doc. Maybe it's easier that way.
Yeah, I've had a quick look at it. Okay, the first one is from a doctor, or I presume you're a doctor, I'm not sure, who's working within pediatrics. And it's true that even with pulmonary TB, you struggle to make a microbacterial diagnosis. Children almost always will catch their TB from someone at home. So if you're thinking about the diagnosis of TB, what you need to do is to look for a positive contact, and you treat the patient according to that positive contact. There are other ways that we can use to make the diagnosis. So first of all, a chest X-ray. A normal chest x-ray, it's uncommon to see a completely normal chest x-ray in a child with TB. Kids also have often soft signs, like they're not playing as well as they used to. They're not quite as active. They're a little bit more sleepy. That is a cause for concern. The question's just disappeared. Oh, is it because I'm answering it?
Yeah, I think I was trying to sort of, I will bring it back.
And there are other ways that we can get sputum from a child. We can do a gastric lavage, but that's quite a traumatic process to go through. Or you can nebulize and then do a suctioning of the upper airways. So that is a possibility to do. We can look for it. But I agree that often in children we say it walks like a duck, it quacks like a duck, it waddles like a duck, it probably is a duck. And in which case it probably is TB. The wonderful thing about children is that they respond phenomenally to treatment. And if you've got the diagnosis right, you will know. Kids often present with so kind of soft signs, chesty kind of child, failure to thrive. And those kids often will benefit by a trial of TB treatment. And if you're right, you'll know that you're right very quickly. I think this is an area for research where we need to be able to diagnose these children more accurately. Nomfundo, you're right. I made a mistake. Continuation is 4 months. And then, so the next question is, why do we tell our patients to take their TB medicines early in the morning before meals? It's old-fashioned. There's no real reason to do it. Some of the pills are associated with insomnia, and we know from work that we've done with dolutegravir, if your patient complains of insomnia, tell them to take their treatment in the morning. But the other thing is that this kind of early in the morning thing kind of tracked back to when we used to use DOT, when we would say to our patients, you know, you've got to come into the clinic to get your treatment. That was not a barrier to adherence. I've got a car and I would battle to go to a clinic every single day for treatment. So I think it's kind of tradition, but the important thing that you've got to do is to take your TB treatment every single day. And yes, it should be taken on an empty tummy. It does depend on your patient's lifestyle, whether they're at work. Sometimes it's just the easiest, but it doesn't have to be like that. I know from when I used to work a lot in the HIV clinic, people would say, I'm afraid to start antiretrovirals because I can't guarantee I can swallow my pills at 7 o'clock every morning. And that became a barrier to adherence. So it's kind of traditional, but so long as it's done roughly at the same time every day. Then the next question is around peripheral neuropathy and INH. So we use INH for TPT, for preventative therapy, as well as for the treatment. And yes, peripheral neuropathy does occur. There is a way of preventing it, and that's by using, just gone out of my mind, vitamin B, sure, pyridoxine, sorry, late night brain fart. So we do need to give pyridoxine whenever we are giving INH, whether it is with as preventative or way of treatment. And the maximum dose you should give is 25 milligrams. If you give much more, you're just making expensive urine. It just gets weed out. So the other NRTI ARVs seldom cause peripheral neuropathy. Stavudine did, DDI did, but the other ones seldom cause peripheral neuropathy. But there are other causes of peripheral neuropathy that we need to watch out for. The one is uncontrolled diabetes. And another one is alcohol abuse. So uncontrolled diabetes, there's lots that we can do about that. We can control diabetes. But alcohol abuse, when you find the cure to helping people to overcome substance abuse, you will win the Nobel Prize. So try and discourage alcohol use in a non-judgmental fashion. Then the next person is asking if you have to take a second sputum after the intensive phase. And the answer is yes, you do, because it is required by our program. What we do is that we look at smear status before starting treatment. And again, we look at smear status at the end of the intensive phase, so at 2 months. Can it become positive? I suppose so. One of the challenges we have with sputum is that, so one of the challenges we have with sputum is that it depends on how well it's done. If I take blood from your left arm or your right arm and I test your full blood count, we're going to get pretty similar results. However, we can take 2 specimens from one patient in one day and get 2 different results. Sometimes it's 3+ positive, and then you ask them to cough in a bottle the next within 10 minutes, and it becomes negative. It's really dependent on the quality. But what we do look at to measure the success of our TB program, at least in the year 2022, is that we look at smear status at the beginning of treatment, and we look at it at 8 weeks. And that gives us a clue whether we're on the right track or not. So your next question is, if the sputum is negative, and I presume you mean by microscopy, but if the sputum is negative by microscopy and gene expert, and you look at the chest X-ray and you think this is very suggestive of TB, what are the chances that you are correct? So it's very high. The ultimate diagnosis of TB is sputum culture. And the problem with sputum culture is it takes a long time to come back. You can declare a culture negative in the laboratory at, pardon me, at 6 weeks. Pardon me. And if you've got someone who is smear negative, often they have advanced HIV disease, and you don't have 6 weeks to sit on your hands and wait. So if you look at somebody and the smear is negative, smear negative, gene expert negative, there's a small window of people who do have active TB disease that will be found on culture. The chest X-ray, you need to add one more caveat. And so if the smear is negative and the chest X-ray is suggestive of TB, and the clinical history is suggestive of TB, then you can start TB treatment. You don't want anybody to get really ill with TB without the benefit of us starting treatment. So we don't want anyone with a pulmonary disease in South Africa to die without the benefit of tuberculosis treatment, anti-TB treatment. So if you think it is, but on the X-ray that I showed you, you can't tell whether that is new or old TB. You can't. So if someone says, look, I had TB 5 years ago and I'm feeling absolutely fine now, and you see the chest X-ray, those were active TB cases. But remember that the third leg on the poikie, as it were, it's what the sputum tells us, what the chest X-ray tells us. But third thing is what the patient actually tells us themselves. If they say, yes, I am sweating at night, I've lost weight, then yes, go ahead and start. And of course, you will start with drug-sensitive TB treatment, so with HREZ.
Francesca, are you able to somehow talk about urine LAM in similar cases and its role?
Yes. Okay, so that's a very good point. Urinary LAM is a very useful test. It picks up parts of the TB bacillus that's found in the urine. It's got limited use. We can only rely on the results if the patient has HIV disease with a CD4 count of less than 100 officially, but probably less than 200. And if the result of a urinary LAM is positive, your patient has got TB, end of story, and needs treatment. If it's negative, it can still be that the patient has got TB, but you're right, that is the last thing that we can do. Is in fact, people who are admitted with advanced HIV disease should have a urinary LAM. And someone who's quite sick with TB, just do it. If it comes negative, don't say to the patient, go home, you've definitely not got TB. But if it's positive, you definitely have TB.
Okay, superb. And maybe because the questions are clustering, I've tried to do some themes. Maybe we will try and
Okay.
cover a few of them, and also try to get you to take a breather in between the
Okay.
questions. So with regards to the questions around sputums and stuff, do we still need to, I mean, is 3 sputums better than 1? And I think, and also for smear negative patients, how else do we monitor treatment progress?
Okay. So no, 3 sputums in the age of a gene expert are not necessary. 1 good quality specimen, unless you work in the Western Cape where they always do 2, but 1 good quality specimen is usually enough. If you do a gene expert, the patient has a negative gene expert and you're still suspicious of TB, the next specimen should be for a gene expert and probably a TB culture. Remember, the fact that we work in an area with high HIV prevalence is not an excuse to practice bad medicine. And we've got a really good National Health Laboratory service that you can send sputum off for culture. So, you know, 3 is not necessary. 1 is usually enough. And in fact, NHLS has a gatekeeping role that you can't do 25 gene experts. And please don't do smears. If you think someone's got to do TB, if you work in private and your patient's medical aid won't pay for it, send them to the local clinic. Don't do smears to make the diagnosis. We miss out richness of the of information on our patients by not doing a smear. Smear, you need 10,000 organisms to make it positive. Gene expert, ultra, you need about 50. So we get much more action from using a gene expert. So what do we do if there's no sputum production? So someone who's got active disease, who's got open cavities, they will almost always produce sputum. But what happens when they come at 2 months and they say, I can't cough anymore? So there are a couple of things that we can do. First of all, if they really, really can't cough, giving a sputum specimen is pretty undignified. But if they really can't cough up in a bottle, you can say it's probably negative. You can also, if you're concerned, you can nebulize the person with hypertonic saline. That's hypertonic, so more concentrated saline than normal. And that will often make them cough, and then you can use that. But this is for a smear, and we need to acknowledge that it's a slightly different mechanism of taking the specimen. So if it's smear positive, then we kind of take it with a little bit of a pinch of salt. We do need to investigate if you've got smear positivity after the end of the intensive phase. We do need to make sure that the patient is being adherent to their therapy and that we have not missed any resistance. Gone are the days when we go, let's try again next month. You've got to deal with that on time.
Superb. Now I'll cluster these 2, then we'll come back to study 31.
Yes.
Just to check how good, is FNA and ADA compared to the gold standard tests that we recommend?
It's so FNA is it's operator dependent, isn't it? It depends on whether you've got to right the center of the lymph node, whether you've got a good specimen or not. If you get a good specimen, the specificity is adequate. If you think it's TB and you do an FNA and you know you've got a good specimen and it is negative, then you can probably rule it out. In terms of ADA, it is the WHO recommended diagnostic for pleural TB in a high TB burden country. And for those of you who don't know, we live in a high TB burden country. We prefer, a proper cytology and a pleural biopsy, but a high ADA, it's good enough to make the diagnosis. Of course, a high ADA does not tell you whether the patient is rifampicin resistant or sensitive. So it's good enough to give you a hint. And it's quite shameful, I think, that in the year 2022 that we don't have really definitive, easy diagnostics for diagnosis of TB.
I see a question from Ndimuhulu. I know she works at the National Pharmacovigilance. I'm not sure what else she's involved in at that level, but she's asking what does the what is the opinion of WHO on the study 31 findings? Are there specific things?
Oh, yes. The WHO has issued a rapid communication saying that in selected groups of patients, a rifapentine moxifloxacin regimen can be used. So the WHO has come out in favor of it. It was a very well conducted study. And I think that now the questions are not, does it work? The questions are much more, should we give it to everybody? What research should we do on the targeted population? So what should we do in the groups, you know, in pregnant women, in children? There's slightly different opinion in children, but it's not, does it work? It's how can we implement it? So study 31, the rifapentine containing regimen, it's far more tablets to take. Rifa-4 is co-formulated as a fixed dose combination. But I think if we wait until we've got co-formulation of the rifapentine containing regimen, this will be okay for my great-grandchildren. I don't even have grandchildren yet, so it's going to be quite a while. So the old way of thinking that we had with TB, that we have directly observed therapy, fixed dose combinations, that's got to change a bit while we're working out whether they can be co-formulated. I think if we give our patients informed consent, if we say you can take 4 tablets a day, and you know, ultimately we change it after 2 months, but ultimately that's going to be for 6 months, or you can take far more tablets for 4 months. Which would you prefer? And let our patients tell us what they want. Maybe some people, the burden is too high. They would say, listen, I'd rather just take these couple of little tablets. And other patients would say, only 4 months of treatment, whoopee-doo, that's what I want to do. So I think that, but the WHO, just in summary, they've endorsed this regimen. And you know, when the WHO coughs, we all get COVID.
I like that. Before we get into issues of TB and ARVs, is there added value of adding additional drugs for susceptible severe TB meningitis? I see Francisco is asking about adding levofloxacin. Will that enhance the effectiveness of the treatment?
Good question. Can we come back to the answer? And in fact, adding linezolid. So it's not in our guidelines at the moment. They're conducting clinical trials to decide how we can improve the outcomes and the addition of other drugs. I think oftentimes in a condition like tuberculosis meningitis, we feel so desperate that we want to do anything that we can to improve the outcomes. You can't be faulted for adding it, but it's not proven yet.
Okay, we wait for science. Now there's a series of questions, and it's mainly because you didn't mention efavirenz when someone has issues with dolutegravir in the TB of context. I mean, in the context of TB. Is there still a place for efavirenz? And I see someone is saying lopinavir, ritonavir, clearly contraindicated. I think it's not true. Yeah.
No, it can't. Look, let's be honest. The vast majority of our patients are treated on a dolutegravir containing regimen, and very few of them have problems with it. So TEE is definitely an option, and I will definitely add it. The problem is that oftentimes by the time we get to treating tuberculosis meningitis, we've blown through our NNRTIs. And we do want to make sure that we're giving adequate therapy. So yes, TEE is an option if the patient is antiretroviral naive. And it also depends on your stock levels, if you can get it. So lopinavir, ritonavir is not contraindicated. It's a possibility. We don't like using it because it's associated with lots of side effects. But ultimately, if someone is going to survive their tuberculosis meningitis, what they need is cure of the TB and adequate antiretroviral therapy. So it was just mentioned as a possibility. But I can't remember when I saw someone last who didn't tolerate dolutegravir very well.
Superb. So with regards to then treatment for TBM, do we need to switch to ethionamide, considering that ethambutol is not very sort of effective?
So first of all, I bet you won't be able to find ethionamide in our program anymore. So we do use it for children, but it is a very poorly tolerated drug. It's very similar to INH. So it's got a similar metabolic, similar similar structure. But no, we don't swap to ethionamide. If you've got INH sensitivity, INH is the way to go. Ethionamide has been dropped from our drug-resistant TB program because it's so intolerable. People say, if I had to choose between taking your medicines and death, I think I might choose death. So ethionamide is a very poorly tolerated drug. If you've got INH resistance that is mediated by a mutation in the INH-A gene, that's an indication for ethionamide. Otherwise, it's very seldom used. We seldom even use it when people have failed.
Maybe before, because we are left with 5 minutes, there were 2 important questions that I would love you to address. And then if we have time, we can still go through the list. One is around how to approach INH monoresistance. And then the other one is about, it seems like there are regions where there's a shortage of RIFA4 and people are asking if there's an alternate regimen. I don't know, but yeah, quite difficult.
Okay, I'm going to take the last one first. If there is a shortage of RIFA4 in your area, please phone the Minister of Health. I'll give you his phone number. Well, if I had it, I would. I'd phone him myself. So no, there is no alternative. So you can treat for drug-resistant TB with a bedaquiline linezolid containing regimen. It's much more expensive. It's not as effective. So please alert the media if you're running out of RIFA4, because that's disgraceful. Sorry, just remind me what the first question was again.
It's the INH monoresistance approach. Yeah.
So first of all, we don't find INH monoresistance because we don't look for it, although that's going to change. So if someone is diagnosed gene expert rifampicin resistance, rifampicin sensitive, we don't do any other microbiological tests. We start them on HREZ. But what's being brought into our program, and it will be really targeted first to the drug-resistant population, is a new gene expert cartridge called the XDR cartridge. And the XDR cartridge looks for resistance to fluoroquinolones and injectables, but also to INH. And I think that what will happen within a year or so is that everybody who has a rifampicin sensitive will then go on to have a reflex XDR cartridge done, and they will look for INH resistance. If you are INH resistant, many patients will do fine on rifampicin alone for their last 4 months, but we don't like to go for what's going to be okay. We want to have signs. So patients who are found to be INH resistant need to have moxifloxacin or levofloxacin added to their regimen and to be given RIFA4 for a full 6 months of treatment. So we add one drug. What we should be doing is taking the INH out and replacing it, but it's much more difficult to get PZA, ethambutol, and rifampicin on its own than it is to give RIFA4, which is commonly used in our program. INH is generally a well-tolerated drug. It causes hepatotoxicity in some patients, and it can also cause peripheral neuropathy, as mentioned before. But at this stage, we just add levofloxacin or moxifloxacin.
All right, superb. I see Anonymous is talking about TB guidelines, and I think probably he's talking about TB meningitis and the duration of treatment.
Yes.
And he's referring to 9 months versus 12 months. I'm not sure if you want to make, that is probably the last question for the evening.
Yeah.
Yes.
I think the fact that we're not entirely sure how long to treat tuberculous meningitis for is a function of the fact that it is difficult to make the diagnosis, and then it's difficult to decide when someone is fully responded to treatment. So we don't have evidence either way, but it appears that 9 months is okay. It's difficult to sort out what's the neurological deficits, whether they're due to active disease or not. And good news, work is being done in the research field on this, and hopefully in a year or two, I'll have some better advice, and let's hope.
Superb, superb. Dr. Francesca Conradi, thank you very much, for your time. This is an informative, very empowering session. We really want to appreciate your time. We want to appreciate as well our sponsor, AbbVie, for making this particular event a success. Before I thank the audience, Dr. Conradi, do you have a takeaway sentence? Because after questions, people can forget that last slide you had.
Yeah,
Yes.
I think my last statement is TB anywhere is TB everywhere. So let's find it. And I see someone put a TB-free generation. It's within our grasp, but we need to find it.